Good afternoon. We're going to get started in about a minute or so, giving some folks a few seconds to find this secret X room. I expect we'll have two 20-minute presentations, one that I'll give on this topic you see here, and one by Dr. Becker from Vienna, who will really talk to us about outcomes in spine imaging and how physiologic imaging impacts on what they do every day. So this is my title. I'm Larry Tanenbaum. I'm from RadNet, which is a large outpatient imaging organization throughout the United States, mostly in California and the Northeast. I am active on Twitter, but I don't have my Twitter handle up on there, but it's at NeuroMRI, NUROMRI, if you want to throw up any comments or criticisms. If you're going to put criticisms up, spell NeuroMRI wrong, if you don't mind, so I don't have to see it. But if it's NUROMRI. All right, so let's go ahead and talk a little bit about physiologic imaging of spine pain and how some of these newer techniques can make a difference in day-to-day practice. As you know, low back pain is a very significant issue. As a matter of fact, standing here right now, I have back pain. It's the number 2 cause of all patient-doctor visits. It's the number 1 cause and cost of disability and workers' compensation. 50% of patients that are out of work at 6 months never return to the workforce. And as you can see, it's a very significant annual cost in terms of dollars, at least in the U.S. At our imaging centers and probably around the world, it's the number 1 indication for MRI at roughly 26%. Well, $10 million per year is spent on spine imaging. $3 million of that is spent on lumbar spine imaging. And it's, again, a very, very common exam. Now, we do get useful information from spine MRI, very detailed information, and we issue reports that are a page and a half long, but often these reports don't have much impact on the outcome of the patient, and that's really the dilemma that we've got. We know about degenerative spine disease. It progresses at a certain rate, and this rate of progression doesn't correlate well with what we actually see in patients in terms of symptomatology, and this is the dilemma. So how can some physiologic imaging techniques that are either out there or just about to arrive out there make a difference in day-to-day practice? So I'm going to show you, a little brief glimpse into what PET MRI might be able to do, looking at the value of physiologic imaging with FDG and using the conjoint availability of both modalities to get additional insights that may help us determine what needs to be treated. But we're going to spend most of our time talking about how MR spectroscopy can give us chemical insights that, again, may point us to the symptomatic lesion. I'd like to say at this particular point in time that I don't currently have a PET MR. We will probably have 2 within the year, but I really benefit from the material that Dr. Sandeep Biswal from Stanford gave me, and I hope I do justice to the cases that he's going to show me. But fundamentally, this is a typical image you might see on a spine MRI examination. This is a patient whose previous spine MRI was felt to be non-contributory. I have one relevant image up on the screen. I think we can all appreciate the asymmetric facet arthropathy, certainly worse on the left, but again, it's hard to know whether this is really the target that we should be attacking for the patient's symptoms. By injecting FDG, we can map metabolism, and here you see the MRI. Here you see the fused PET MRI acquired at the same time, makes fusion just a bit more accurate. And here you see the FDG imaging, and you can clearly appreciate that there is asymmetric activity associated with the left facet joint and also the surrounding soft tissues. And you have additional assurance that that might be a good target for treatment. Here you can see on the coronal reconstructed images, there's some abnormal signal within the left S1 nerve root. If you look at the physiologic imaging, you can see abnormal signal in the paraspinous region around the facet and also in the nerve root, giving us additional information in terms of credibility. All right, here's a patient with right-sided S1 radiculopathy. We all can appreciate the disc derangement. Problem is, disc derangements are very common, roughly a third of patients. If we were looking at an asymptomatic population, it's hard to know what it means. You can see from the coronal images, there's some abnormal signal associated with the S1 root. When we look at physiologic imaging, and this is kind of small, but if you look at the PET image, you can see that there's abnormal tracer localization associated with the S1 nerve root. Again, telling us this nerve root is hot, physiologically active, and probably a good target for intervention. You can see our anatomical images. Again, look at how the tracer activation goes right to the nerve root, telling us that we should probably do something to relieve that nerve root's compression. As a matter of fact, if you follow the whole body out, you can see that the biceps femoris muscle, which is innervated by S1, and a significant portion of the population is also very hot in terms of physiology. So kind of a neat thing. Now here's a patient with real symptoms, left-sided symptoms. The MRI is unremarkable. At Stanford, they do a whole body PET on every one of these exams to see what else they might find. And while the spine was unrevealing, they actually found a hot spot in the patient's calf. And this turns out to be a scar neuroma. The patient was skiing. He clipped the back of his calf, probably while he was doing one of those freestyle things we saw in the Olympics. Next thing you know, he's got a scar neuroma, and it's the symptomatic lesion, and it isn't really coming from the spine. So, we've kind of talked about the dilemma we have out there. It's really difficult to identify the source of spine pain. And when it comes to discogenic axial spine pain, it's even more difficult and, again, more important, because if we can isolate that disc with treatments or fusion, we can actually make patients a lot better. And to make that diagnosis, you need a number of things that you can see on the screen, but most importantly, you need to be able to identify the pain-generating pathology so that you can attack that. Much like we saw fluorodeoxyglucose show something is hot, here we're looking for where is the pain-generating pathology. We know our MRI is really good. It's quite exquisite. We can go to 17 now, probably see structures we've never seen before. But again, this is more about functional information. Where is the pain coming from? Traditionally, we do provocative discography to look for pain. What is provocative discography? Well, you inject the disc under low pressure. If you reproduce the patient's symptoms, there's a positive discogram. We often do a disc of at least one control disc, sometimes two, because we like to be sure the pain is coming from that disc and not from the other levels. And as you can see, my buddy Dr. Johnson looks very comfortable during this procedure. It all looks very simple and easy, but it's not so easy for the patient. It can be relatively uncomfortable and painful for the patient, so we have to bear that in mind. Here's one of his cases, a typical spine exam. We can appreciate loss of disc height at L4-5, probably also a central herniation. But again, this can be an asymptomatic lesion. He did discography at L3-4, at L4-5, and L5-S1. And at L4-5, he was able to reproduce the patient's symptoms. And that's the classic clinical scenario for a positive provocative discogram. Discograms, physiologic information like we get from discography, can be very, very powerful and can avoid unnecessary surgery. And this particular paper, where my buddy Dr. Johnson was an author, they showed that if they took all patients on the way to fusion and did a provocative discogram, roughly 40% of those patients will not get surgery because the discogram will show it is not a symptomatic disc. So this is a real dilemma. Problem with discography is it's somewhat controversial. There's some folks feel the false positive rate is very high, while other folks feel the false positive rate is appropriately low. So, it's a constant discussion going back and forth. What is really relevant and hard to dispute is if you stick a needle into a normal disc, the disc begins to fall apart. In this 10-year follow-up study, they showed disc degeneration, herniations, loss of disc height, all the sequelae of an injury to the disc, all from that injection. And remember, we're not just injecting the suspected symptomatic troublemaking disc. We're talking about injecting a normal control disc. It's minding its own business, and now we've created some irrevocable harm. So imagine we could get this physiologic information without punching a hole in the balloon and causing irrevocable harm. And that's kind of what we're talking about. So while these exams are done quite often, they're very powerful. They're functional, as I pointed out, and can be cost savings by avoiding patients getting surgery that won't lead to relief. They are relatively painful, as you can see. They are somewhat subjective and variable and controversial as a result. They do produce some degree of injury to unsuspecting happy discs, and it would be awfully nice if we had an alternative. So, that's the problem, right? Here are 4 images of lumbar spine patients. Most of these patients are symptomatic. One is not. If I asked you to pick out the one that was most likely to be symptomatic, you might jump on this high-intensity zone. You might not. When we do discography in these cases, you can see the pluses and minuses. You can see which ones were symptomatic, which ones were not. The case I pointed out, he was actually an asymptomatic volunteer. who's been studied multiple times with the techniques that we're going to talk about. But you can see in this case, we're looking at a positive L2-3. Here we're looking at a positive L5S1. It's hard to pick out which discs are symptomatic from simply looking at the anatomical images. And by the way, if you operate on levels that don't correlate with positive symptoms, a positive discogram or some other indication that it is a painful disc, again, with fairly unremarkable, fairly unimpressive and depressing surgical outcomes, only about a 50 to 60% success rate. So what else can we do with an MR scanner to pick up physiology, to pick up chemistry? Well, there are techniques like MR spectroscopy. They've been around since 1995. I remember doing these in brain images in 1995. And every high-field scanner on the market can do spectroscopy. Essentially, we're looking at a chemical tissue signature. We know that in brain tumors, choline is elevated, and therefore the elevated tissue turnover might be a sign of a neoplasm. It's still in routine use for brain lesion characterization. We know it's not specific, but it is a powerful tool to see certain things. But there are technical challenges in the brain. There are technical challenges in the prostate and the breast. As you might imagine, the technical challenges for the spine would even be worse. We got a small structure, you got a lot of bone around. It takes a lot of finesse and a lot of attention to make it work in the spine. But the nice thing about it is that, certainly in the hands of the early investigators and now this commercially available product, they've done very well. And you can see actually on the right-hand side of each of these frames, the scoring of the disc chemistry based on MR spectroscopy. Here it's called Nocimed, which is what the commercial product is called. Which is, again, you'll notice from the bottom of the slide, just recently CE-marked in some European countries. But see how well they correlated with the actual discogram in these particular examples with perfect correlation what I'm showing you. All right, I got to remember which button to push to make my slides advance. All right, so what are we actually going after here? Well, there is certainly a phenotype to the painful disc, and they're characterized by hypoxia, lactic acidosis, inflammation, neovascularization, and neoinnervation. And if there are classic chemical signatures, we clearly have the potential to sample for these and characterize these with a technique as sensitive to metabolites as MR spectroscopy. We do know that acid accumulates with disc degeneration, and acid is a very powerful nociceptor, so it correlates very well with pain. And, we can actually do spectroscopy of these samples. And here, if anybody has an 11T scanner in their backyard, you can go out and do this tonight. You can take these, when they took samples out from scoliotic patients and patients with painful discs and positive discograms, you can see classic metabolic signature changes. And this would be a normal disc taken from a scoliotic patient. If you know brain MRI, NAA is the peak is a marker of neuronal health. In the disc, it's proteoglycan and collagen. In this case, you see proteoglycan as a tall peak, and lactate is a relatively small peak. With disc degeneration, we lose our normal healthy disc markers like proteoglycan and collagen, and we elevate the unhealthy, the acidotic markers like lactate, and you get that reversal. It's a very, it seems very binary, at least at 11T, and you can see they did very well at 11T, separating the two different groups. So the potential is certainly there, although I'm not sure you have an 11T scanner in your backyard. Here you can see the kind of results we were getting in the early days. Here's that typical patient with a high intensity zone, but an asymptomatic volunteer. And there you can see the typical disc spectra that were achieved with the platform, and you can see the proteoglycan peak and really not much lactic acid to speak of. Here is another patient. This one actually has a positive discogram at L5S1. Again, you see the spectra from L1 through S1 here. If we take a closer look at the abnormal spectrum, you see that reversal of the typical ratio, suggesting that this is a disc with abnormal chemistry. This one is screaming, take care of me in that case. Now, things have moved along over the years, over the progress to commercialization. This is kind of what the spectra will look like now if you were to go ahead and use a commercial product. Things have been cleaned up quite a bit. There's a lot of image processing that goes on in terms of making this a palatable, clinically useful tool. But here you can see the typical peaks. I've got proteoglycan here. You can see the collagen peak here. You see you can actually appreciate the lactate peak and even a propionic acid. If it was present in the disc, you would actually be able to pick that up. And those of you who are aware of the issues with propionibacter and its potential etiology in spine pain might find that captures your imagination. But bottom line is, if you were to, and there's a number of different ways that this is done that I really won't dwell on in my last 6 minutes. But essentially, if you take the pain markers and put them in the numerator and the structural integrity markers and put them into the denominator, the denominator goes down with an unhealthy disc and the pain markers go up with a painful disc, you have a pretty striking ratio that's going to point you to symptomatic discs that we might go after. And this can be displayed in a number of different ways, with and without corrections and normalizations. And I imagine this is going to be customizable, although the normalizations seem to produce better results. And these heat maps are also very nice, and I think will convey very well our findings to our clinical colleagues. But you can see the L5-S1 level is red hot, and so is the L3-4 level. It's a little bit a hint of something going on at L2-3, but it's really not very strong signature. And as you can see, the provocative discogram was normal at 2-3 and normal at 4-5, but 3-4 and 5-1 were positive discograms. And you can do this with normalization. You can do this by cutting off the top of the peak, but they all tend to point to the same direction, that these are symptomatic discs. And if you take the raw Nocimed score and you take the normalized Nocimed score and put them on different axes, you can see how well separated these discs are. And even the disc with mild involvement ends up in this mild zone here that you'd say, well, gee, I don't know about that disc. We'd have to do a more careful clinical correlation. But the two positive discs are soundly in the corner where you can feel comfortable that this is a positive case. And here you can see, just looking at the Nocimed score plotted in this fashion, you've got these big red markers here to tell you this is where my interest is, and you might take a look at that one a little bit more closely. Now, I think the most remarkable part here is how this information can affect outcome. The L3-4 disc and L5-S1 disc both ended up being fused, and you can see whether you look at the disability index on the left or the visual analog scale for back pain on the right. Pre-op, the numbers were very significant. Post-op, major improvement on disability and substantial improvement in terms of pain. So physiologic imaging, pointing you to the troublesome disc levels, treat the disc levels, outcome improves, and that's really the key piece. Here's another case. You can see it looks like I've got a bad disc on imaging. We don't really have any sense that it's symptomatic. The chemical signature is screaming abnormal. You can see this case was eventually treated, and you can see the pain index and the disability index markedly improved after identification and then directed treatment to the disc. And you'll hear a lot more about treatment from my colleague, Dr. Becker, who's going to follow me. Here's a third case. Again, look at the discs. You've got some degenerative disease from L4 through S1. Again, no real indication which one is symptomatic. You can see there's a herniation at 5-1. The spectroscopy scores, Nocimed scores, are screamingly positive at L4 through S1, clearly negative at the other levels. And again, by using this physiologic information, turning this into therapeutic interventions, we can get the effect on outcome that we're hoping for. I think that's pretty exciting. So what you've seen so far are test cases and principles. Thus far, over 300 subjects, 1,000 discs have been studied on multiple MR platforms. At this point, it is commercially available on the Siemens platforms, on the 3T platform, Skyra and soon Vita, and the Era, and hopefully Sola in the near future. As you've seen, it's a big market potentially, but it's a small voxel, and there are some technical things that had to be overcome. I mean, that's what we've all done. Who's done spectroscopy? Okay, somebody has. Not of the disc of the brain, anything. You're used to seeing that picture, right? It's very hard to make some sense out of that picture, and we all look to computerized smart algorithms, AI type technology to take that and pick out the signal, and that's really what's going on here. We've really gone ahead and processed the signal. It can pull out the information with from out all of that noise, and there's a lot of challenge in what the manufacturers give us in MR spectroscopy, and just being clever about choosing channels and processing data can make a big difference. Motion, always occurs in the spine, so correcting for motion can take an image that looks a bit amorphous and isn't as revealing and turn it into something that gives you useful information. There have been a lot of study in terms of how to look at the scores, whether we do them, with cutting off the top of the range or normalizing to the patient's own discs. A lot of different ways to look at the data, but this has been pretty well refined and ready for clinical use. And again, there are the biomarkers that I've pointed out, as well as the potential for additional biomarkers like propionic acid or any place your imagination may take you that will take us to the next level. What does it take to get this done? Well, it's a cloud-based application. You simply hook up to the cloud-based application via the Ambra DICOM pathway, which is a very commonly used tool. And essentially the data goes up, it gets processed, it comes back in a reasonable amount of time. And I think that's really the fundamental workflow. It takes a while to do the exam. I think right now we're talking about, adding about a half an hour to a conventional MR examination, and, one hopes that there will be the appropriate reimbursement and billing associated with this, since it does seem to replace other tests that, that have a significant cost and produce the same results, much as we're seeing in other fields where, say, maybe an analysis tool like I can't even think of the name, an analysis tool that might replace a cardiac cath in cardiac CTA.